Hi, everybody. Welcome. Come on in. We'll get started here in a second. All righty. It is the top of the hour. Welcome, welcome. My name is Alan Barr with COEH Northern California. And on behalf of the NIOSH-supported education and research centers throughout the country, we're pleased to present the 2024 ERC Ergonomics webinar series, where we offer free monthly webinars on various topics on human factors and ergonomics. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Thank you again for joining us today. If you logged in today via your registration email, you will receive a link to an evaluation form that will qualify you for a certificate of completion. That's worth one continuing education contact hour. Please consider joining us next week on the 27th. We have a webinar titled Workplace Mental Health, Embracing a Population Health Framework. And our next ergonomics series webinar on April 17th is Occupational Ergonomic Research in the Pacific Northwest. And you can register for that or for those and other upcoming webinars at coeh.berkeley.edu/webinars. You will be muted today during the presentation. If you'd like to ask a question, and we encourage you to do so, please enter it into the online Q&A. We'll save some time at the end of the presentation to address your questions. Today's webinar is being recorded, and it will be made available along with past webinars on the COEH Northern California YouTube channel. Please take a moment when you're there to like and subscribe to help us continue to grow that channel. As you can see from the splash screen, today's talk is Patient Handling Hazards and Prevention. And our speaker, Dr. Danya Kiydal, also an MPH. Dr. Kiydal is a medical resident in the Occupational and Environmental Medicine program at the University of Cincinnati. She received her Doctor of Medicine from the University of South Florida, Morsani College of Medicine, and her Master's in Public Health from Columbia University, Mailman School of Public Health. With that, it's my pleasure to hand the microphone over to Dr. Kiydal.
All right, thank you for that introduction. Yeah, so I wanted to thank everyone for joining me today and giving me the opportunity to present on this very interesting topic. As Alan mentioned, I'm an occupational medicine resident at the University of Cincinnati. And the way that I became interested in this topic is that I actually had the opportunity to be a part of the assessment process for initiating a safe patient handling and mobility program at the University of Cincinnati Medical Center. And so that was a very informative experience where I learned a lot, and so I'm happy to have the opportunity to share about this topic with all of you. Okay. Here we go. All right. So first, I just want to touch a little bit about what we're talking about, which is manual patient handling, the problem. These are kind of a bunch of images that show patient handling tasks that are actually being performed with the recommended biomechanical strategies. So nurses and nurses' aides are constantly moving patients throughout the day. This includes repositioning a person in bed, moving them from bed to chair and vice versa, moving them from chair to commode, etc. Lateral transfers, which refers to when you're kind of sliding somebody from, say, a stretcher onto a CT table or any kind of like lateral transfer of a patient from one bed to another. And then rolling and lifting body parts for different procedures, and assisting patients with ambulation. So in a single shift, an ICU nurse can lift up to 3 tons, partly because they're dealing with very dependent patients who are not really able to do much movement themselves. So there is just an incredible amount of physical labor in the work that these healthcare providers do. At the same time, the lifting and mobilizing of patients is extremely important for patient well-being. Within the first 24 hours of admission, older adults will already start to have physical deconditioning, which means that they become physically weaker because of a lack of movement. So it's actually quite common for a patient who entered the hospital able to care for themselves to be discharged into rehab facilities, not because of their original medical condition, but because of the weakness they developed from spending so much time in bed during their hospitalization. Um, Another issue, of course, is that patients who are weak are at risk for falls. And so that often leads them to be spending more time in bed since providers don't really want to get them up and risk a patient fall. And so because they're staying in bed more, they become weaker yet and more prone to falls. And so it's kind of a vicious cycle that develops. In any case, the weakness from physical deconditioning in the hospital can often be irreversible, particularly in older adults who make up the majority of the hospital population. Um, so there's really a huge push to get patients mobilized early and frequently. And that means that there's more pressure on nursing staff to move patients more. So another common issue in the hospital is the development of bed sores or decubitus ulcers, typically in patients that are, again, not really able to move themselves very much. So pretty sick, dependent patients. So by most guidelines, a dependent patient will need to be turned in bed at least every 2 to 3 hours to prevent bed sores. Additionally, Medicare and Medicaid won't reimburse hospitals for the care of these ulcers if they occurred while in the hospital. So again, there's just a huge push to increase the amount of moving patients for nurses and nursing staff, support staff, uh, even more than they traditionally have been doing, which has been quite a bit. Okay. So manual patient handling is dangerous. According to NIOSH, the single greatest factor in overexertion injuries in healthcare workers is the manual lifting, moving, and repositioning of patients. Now, this data I have here is coming from the Bureau of Labor Statistics for 2021-2022. And it's showing that the rate of overexertion injuries, which is where um, handling injuries kind of fall under that category. The rate of overexertion injuries leading to days away from work for nurses, and especially nurses' aides, is far greater than what you see on average for other occupations. So the average for occupations, as you can see here, is 26.1 injuries per 10,000 full-time employees. For nurses, that's 45.4. And then for nursing aides, that jumps up to 145.5. So it's a huge burden. Okay. The healthcare industry has just consistently ranked among the industries with the highest rates of musculoskeletal injuries. And that's largely explained by patient handling. Anywhere from like 30 to 70% of reported musculoskeletal injuries in the hospital are related to patient handling. So I want to point out that all of this data only includes injuries that have been reported. Um, and the literature suggests that as much as 50% of patient handling injuries actually go unreported by nurses. So all of this has a pretty significant impact on nurses and nursing aides. Several studies have demonstrated that more than half of nurses suffer from low back pain. The annual incidence, the annual prevalence in this population for shoulder pain is about 44%, and neck pain is about 42%, according to a meta-analysis that looked at studies over the course of 30 years. And then in 2001, the American Nurses Association conducted a survey study wherein they found that 60% of respondents reported that disabling back injury was their most important job safety and health concern. So although it's an old study or old survey, I think that the point is still very valid, particularly because manual patient handling hasn't changed that much in terms of what staff are expected to do if they don't have engineering support. Okay. Additionally, between 10 to 20% of nurses end up leaving the field because of a work-related injury. And so that's a huge issue, particularly since we have a shortage of nurses. Okay. So here are some graphs from my assessment at UCMC that are depicting, who was injured and what body part was injured during patient handling tasks over the past 3 years at our facility. And the results are generally consistent with what has been reported in the literature, with exception of what we see here with PCAs making up kind of a smaller percentage of the injured persons than I would have expected. But as you can see, RNs make up about half of the injuries that we encountered. And then physical therapy, occupational therapy, patient care assistants, radiology techs make up are the groups most impacted by patient handling injuries. And consistent with the literature, we found the back, of course, was the most commonly injured site, followed by the neck and shoulder. In our case, we found the shoulder was more commonly injured than neck, but in other studies, that can be flipped. So it's just, those are the major body parts that are injured. Okay, and here's another chart from my assessment at UCMC. And as you can see, by far, repositioning patients in bed is the most risky patient handling task. And that, again, is consistent with what you find in the literature. So traditionally, healthcare providers have been trained in these kind of biomechanical techniques for moving patients in the hope that that would decrease injuries. And as you can see from these examples, even the proper using proper body mechanics, this is very labor intensive. I attempted to do this activity to move my husband, and I was concerned that my shoulder was going to pop out. So you know, they're not ideal. And um, they're certainly very labor intensive, especially when you consider overweight patients and patients who are unable to provide a lot of assistance with their movements. So the research has shown that these interventions of just using proper body mechanics are really ineffective in preventing musculoskeletal injuries. And they may actually just be contributing to the cumulative injuries that nurses and nursing staff experience, um, or nursing assistants experience um, from moving people in this way. All right. So most of you are probably familiar with the NIOSH lifting equation, but in case there are people that aren't, I'm going to kind of go over it a little bit. This is basically an equation that helps determine what a safe amount to lift is given the circumstances of the lift. So we start off with kind of a base weight of 51 pounds that most people can probably safely lift from kind of a waist to chest height. And then every factor here, so there's a vertical factor, asymmetric factor, horizontal factor, um, increases the risk of the movement. So all of these factors increase the risk of the movement that's being performed. And as you add those, include those factors into the equation, it drops the amount of weight that can safely be lifted. So for example, in an ideal situation, most workers should be able to lift that 51 pounds from like waist to chest. However, if you're lifting from the ground, so you get this vertical factor in, then the weight needs to be lower than 51 pounds. If the item is further away from you, then also that's going to drop down the amount of weight that can safely be lifted per the equation. So the developers of the NIOSH lift equation specifically said that this should not be used for lifting humans. And that's because none of these factors take into account the unpredictable behavior of people, because it was designed for inanimate objects. So nonetheless, one of the authors, Dr. Thomas Waters, adjusted the equation a little bit and placed some conditions under which the NIOSH equation could potentially be used. So these are the conditions that he put it forth. So the patient can follow directions and is not combative. The amount of weight that the caregiver handles can be estimated. So that would mean that, you know the weight of the patient and you have a decent idea of how much of their own weight they're able to carry. The lifting is smooth and slow, and the geometry of the lift or the body and hand positions in relation to the object being lifted and the amount of weight being lifted are not subject to change. So that would be like your patient is the amount of weight that they can carry themselves is consistent throughout the lift. So for example, if you're helping someone ambulate, they're not prone to passing out because then you would go from partially assisting them to carrying the entire weight of that person. So that would be a situation where the condition is not met. Anyways, so per Dr. Waters, as long as these conditions are met, then you can perhaps determine a maximum patient weight. And so under those conditions and ideal lifting circumstances, Dr. Waters determined that the maximum patient weight that can be lifted relatively safely is 35 pounds. So that's not really much weight at all when you can consider what nurses are actually lifting. In any case, so 35 pounds has essentially become a kind of standard for what a safe lift is. And a lot of tools that kind of guide you in determining uh, manual lifts versus assisted lifts. We'll use that as kind of a guide. But I think it's important to still recognize that NIOSH does not consider 35 pounds as a kind of recommended exposure limit or anything like that. Per NIOSH, there's really no amount of manual patient handling that should be considered safe. And they really promote the idea of just eliminating manual handling as much as possible. Okay. So here are some nice examples that came from Dr. Waters' article that kind of just give you an idea of what we're looking at or thinking about. So in this situation, the first situation, a nurse is responsible for raising a patient's leg off the bed while preparing the leg for surgery. That patient weighs 250 pounds. Can they safely lift that leg manually? The second scenario is two nurses are helping a 180-pound patient stand from a chair. The patient can partially assist, lifting about half her weight. Can these two nurses safely lift that patient or assist that patient? And then four nurses are about to move a fully dependent 200-pound patient from bed to chair. Should they use a device? So I have the answers for you on the next slide, no worries. So as far as the first scenario, there's kind of this guidance that a 150-pound person has a leg that weighs about 24 pounds. Somebody that's 250 pounds, their legs generally weigh about 39 pounds. So in that case, a lift or some sort of device should be used to lift the leg. It should not be lifted manually. Now for the second case, again, you have a 180-pound patient. She can carry half her weight. That leaves 90 pounds to the two nurses. You split that between them. That's each nurse carrying 45 pounds. It's too much weight. They should use a device. And then our third scenario, four nurses are trying to move the 200-pound patient from bed to chair. The patient's not able to offer any assistance. And so that's 50 pounds to each nurse, too much. They should use a device. Okay. Let's see. So, of course, with 35 pounds being the weight, the limit of safe lifting, there's not a lot of lifting that you can really do, or you should do in any case. And so there's numerous effective devices that are available now for patient handling. And most hospitals will have some of these devices. So here we have a Hoyer lift. This is a ceiling lift. This is a sit to stand device that, is going to be helpful to get a person from one chair to another with those kind of transfers. This is an ambulating device, which is really good for, keeping patients strong and walking without risking them falling. And this is a really cool thing called the Hercules sheet. And what it is basically a conveyor, like the sheet on the bed is like a conveyor belt where that will pull the patient up in bed. So I don't know if anybody has been in the hospital before, but generally one of the repositioning tasks that needs to be done constantly is just pulling a person up in bed because they're constantly sliding down. And so this sheet, acts as a conveyor belt and takes care of that burden. So it's very cool. And that's just a sampling of the kind of items that are available. There are other things as well. In any case, so I said that most hospitals have some of these devices, but just having the equipment is really not enough. Several studies have demonstrated that most of the time the devices go unused. So generally only about 30% of nurses use lift devices. And that's kind of an average. I mean, the percentage will vary depending on the specific hospital that um, the specific institution. So why aren't these devices being used? So there's a lot of obstacles to their use. The two men that well, sorry, the two main reasons are just accessibility of the device and workplace culture. So I'll give you some examples of what we found in our assessment at UCMC. So in our hospital, most floors shared a single lift, and staff did not necessarily know where that lift was stored. Um, and because they shared, it could move around the hospital a little bit. About half of the lifts that we saw were not plugged in to the wall, and that makes them unusable because they do need to be charged. And then a lot of the lift equipment generally requires a sling to put the patient in. And so because the slings are cleaned by housekeeping, they're stored with the linens rather than with the lift equipment themselves. So that creates another obstacle to use. And then we found that there really hadn't been much routine training in using the different devices. And so, given all these barriers, it's pretty understandable why the lift equipment would not be getting use. Other issues that are pretty common um, is that the lift equipment is not compatible with kind of the doorways or the beds and chairs on the unit. So, for example, you just can't get the lift close enough to the bed to get the patient on it. Um, so those are some issues that can present. Probably less common nowadays as um, um, you know as lift equipment is becoming um, really a lot more accepted and used. Um, and then other issues is that the equipment just hasn't been well maintained, and so it doesn't function reliably. So those are some big issues. And then as far as culture goes, in the healthcare field generally, there can be a culture of self-neglect. Um, so especially amongst nurses, there's kind of an attitude of you got to do what you need to do for the patient and not worry about yourself. Especially when that comes to like, taking a few extra minutes to get a device to help save your back. That a lot of times that doesn't jibe that well with the nursing staff. Although when you flip it to be this is actually also better for the patient, then I think in some cases you have better acceptance. But anyways, um, so a lot of times staff can also worry that using the equipment will interfere with their workflow or it takes too much time. Or sometimes they're just uncomfortable with using the equipment. So all of those things are kind of related to just not having enough exposure to the equipment. Um, so per the literature, really lift equipment is adopted much more readily when there's a strong culture of safety that's promoted by management and it's kind of expected that people are going to use it. And if that expectation isn't there, then it's, you know, it makes it less likely for people to go through the effort. Even though in the end it helps out tremendously. Okay, so here we go. Um, so safe patient handling and mobility programs address a lot of the barriers to the use of lift equipment with good success. These are comprehensive programs that really try to shift the culture and practice of the institution to make manual lifting minimized or obsolete, ideally. So some of the important elements is going to be having developing a policy, a minimalist or no lift policy that's really well publicized at all levels of the organization and shared with um, the staff as well as the patients themselves. Um, and then, of course, another element is knowing the needs of your patient population and your nursing staff, of course. Um, so that would include like selecting equipment based on the hazards and needs of the population that is being cared for. So, for example, an ICU unit will have different needs than a general medicine unit. So it's not enough to just, say, all right, every unit gets 3 lifts and blah, blah, blah. It needs to be tailored to what that unit requires, um, based on their patient acuity and all of that. Um, and then, of course, education and training is essential. You really need to have regular hands-on training on using the equipment so people feel confident that they can use it. And the other big element is management and staff involvement. So these safe patient handling and mobility programs should ideally have committees that include every department that has a stake in the process. So, of course, that includes nurses on the floor to kind of help select what equipment they would like to use or makes sense to them. And that would include even like the housekeeping staff to um, make sure that everybody's aware of what pieces need to be in place to make sure that the equipment is really accessible, convenient, and everything is um, lined up. Um, and then, of course, as with any, um, improvement intervention, you need to have regular evaluation to make sure things are working and determine how you can make things better. And then, of course, the fundamental component of a safe patient handling and mobility program is that every patient um, that is admitted to the hospital is given a mobility assessment as soon as they're admitted and probably repeated throughout the hospitalization. So that would kind of include an assessment of how well this person is mobilizing on their own. And based on that, what specific equipment should be used when dealing with this patient. Um, and the information about what equipment needs to be going with that patient needs to be communicated to the patient himself and his family, as well as any healthcare provider who's coming in to care for the patient. And that really sets the expectation that, yes, we're going to be using lift equipment for everyone. So the VA actually has, the VA is a wonderful resource for safe patient handling and mobility program information. They have a great program in place. And they actually offer an app that helps healthcare staff make the mobility and equipment determinations. But there's, of course, a variety of um, um, item, a variety of tools that kind of help you gauge, okay, based on this patient's mobility level, what tools should we have? So what I have here actually is from Johns Hopkins. I chose this one just because it showed up nicer on the PowerPoint. But they have the different degrees of mobility and what types of tools you may want to use for that patient. So it's pretty simple, but helpful, I think. Okay, so safe patient handling and mobility programs have been around for a while now, and they have shown an incredible amount of success where implemented. in reducing patient handling injuries, but also reducing lost and restricted work days, um, and nursing turnover. On the patient side, they result in reduced patient falls and hospital-acquired pressure ulcers. Um, One meta-analysis that looked at pre and post intervention studies found a 56% reduction in patient handling injuries after implementation of a safe patient handling and mobility program. Um, According to the American Nurse Association, uh, these programs cut or safe patient handling and mobility programs can cut workers' compensation costs by as much as 85% and lost work days by about 76%. So there's a whole host of like case studies of hospitals that have implemented um, um, comprehensive safe patient handling and mobility programs and have seen like very remarkable um, financial benefits in terms of like workers' compensation and lost work days and other benefits to the patients and the staff, obviously. So because of all these benefits, the costs of implementation of a safe patient handling and mobility program is typically recouped within 1 to 4 years. So it's really worth it. Um, so a few states have actually taken some action on this issue and have put in place standards that hospitals need to have some kind of safe patient handling program. Um, so presently there's about 9 states that have such a program in place or such legislation in place. Um, and definitely state legislation is associated with improved safe patient handling practices in hospitals. So I would say it's a very helpful um, push to get hospitals to put that into practice. Okay, so I just have a couple of final takeaways. Um, Manual patient handling tasks are a major contributor to musculoskeletal injuries in the healthcare field. There are effective engineering controls in existence that can remove much of the risk, but they're just underutilized due to inefficient systems. So safe patient handling and mobility programs are really needed to protect healthcare staff and ultimately have proven to be beneficial not only to employees, but also to patients and to institutions' bottom lines. So they, yeah, you would think we'd see more of them. Okay. Thank you. That's it. Any questions?
Thank you, Dr. Kiydal. Yes, we do have a couple of questions for you.
Okay. See
If
if I can.
if anyone has some questions that they would like to pose, please take this opportunity to drop them into the Q&A box. Okay, I'll start at the top here. Have you compared your analysis to home healthcare aids, which may have less ergonomic device availability to move patients than a hospital or a short or long-term recovery facility?
That's a really good question. And I was pretty strictly looking at kind of hospitals because yeah, home healthcare aides, they're for the most part, they're not going to have access, I think, to a lot of the lifting equipment. Um, and so I imagine they're going to be doing, you know, they're going to be relying more on the traditional kind of manual body mechanics. Um,
Okay.
but
Have you
that's yeah. That's a question. Hmm.
do you have you ever heard of any sort of uh, dedicated patient handling staff, like staff whose job they're sort of hired on
Yeah.
the idea that they are just built in such a way that they are able to handle patients all day, sort of physically, which sort of that concept lends itself to patient interaction and more patient mobility, more patient involvement in the motion to preserve muscle and so forth. Is that a concept that you've heard discussed, and is it applied anywhere? Do you have results for
Yeah.
something like that?
Yeah, that's an excellent question. So absolutely, there are some hospitals enact lift teams, which are people who, they're hired just for lifting, and they're trained specifically with the, obviously the lift equipment. And I know in Tampa General, they have that kind of system where there's staff whose responsibility is just to go from, patient to patient, rotating them. And then there's also people that are kind of on call, right? So if you if you have a patient that you need to have lifted or moved for whatever reason, you call them and they can be there in like 5 minutes and lift the patient, something like that. So definitely some hospitals have invested in just lifting teams that have um, really been pretty great, I think. Yeah.
Okay, thank you. Next question. Are you assuming your cohort is a healthy population? Some nurses and aides may be compromised by age, conditioning, and other confounding factors.
Um, I'm not really assuming anything about well, I don't think I'm assuming anything about the cohort. Um, what I guess I guess that would be the assumption if you're saying 35 pounds is a safe amount to lift, because certainly um that's perhaps safe for a healthy person or a strong, healthy person who's at their best. But, for maybe an older nurse or somebody who has an injury already, certainly that would not be as protective. So I guess that's the scenario where you would say um, that there may be some assumptions about the health of the staff. Yeah.
Do you have any tips on how to enforce the use of equipment?
So I think actually the main thing is just to have the equipment really accessible near the patient rooms. You need to have enough equipment for the need of your patients. So you can't have people waiting in line to use equipment because that's just not going to encourage use. And I feel like that's kind of the situation that you sometimes have. I mean, people don't wait in line. There's just not enough equipment the for the need. So I would say that's probably the biggest thing is just having enough equipment located right there where it's needed. Um, yeah. And then having a culture that where it's encouraged and expected of staff to use the lift equipment. Um, yeah, because otherwise there is a risk that sometimes, anyways, for staff to feel like they're maybe depriving their patient of more rapid care because they need to get the lift equipment, which is completely false, right? Um, so I think it's important for everyone to understand that this is good for the patient as well. Um, a lot of times it's actually more comfortable for the patient to be lifted or to you know be moved with lift equipment rather than the struggling nurse. So
Okay, here's one that sort of asks, I think asking more for your opinion. It says, does the intermittent use of lifting devices place nurses and other caregivers at higher risk of injury? It would seem that the muscles being trained by moving patients, so sort of staff conditioning, if you will, daily would atrophy when using mechanical lift. This could place staff at increased risk of injury in emergency situations where patients have to be moved urgently. So it sounds like the questioner is really asking about the dangers or the potential danger of deconditioning hospital staff by using lifting devices. Do you have thoughts
yeah,
on that?
yeah, that's an interesting question. So I know for one thing, the physical like strength of staff does not make them less likely to get injured. So that um is not really, you know, I mean, that I guess it doesn't make them less likely to get injured. But I guess the question more is, um, are they gonna become weaker because they're not lifting patients? And I honestly I don't think that all of the lifting and moving is necessarily like a an exercise program.
Yeah, I tend to agree with that.
Yeah,
It's not really
so
there. Yeah, this is more of an occupational exposure versus what you might do outside of work at a gym, and the two regimens are
yeah, like these
considerably
activities
different.
are not, yeah, they're not really normal activities for people to be doing. So I don't think that that's a great argument against.
Okay, so here's one for you. When considering safe patient handling techniques, have you explored in the discussion around the conflict between staff safety, that's using the assistive devices, and patient rehab goals, promotion of person-centered restorative care, ethical decision making, etc.? There has been some discussion around supporting manual patient handling methods to favor mobilization and increasing patient abilities. Have you encountered this discussion? And if so, would you mind sharing your insight?
Um, you know, I haven't seen too much about that, but I think that like these devices actually support moving patient or getting patients ambulating and moving more um frequently. So um I I mean, for example, you could see that ambulating device where like just the guy's like hanging, he's walking, but he has like a safety belt on him that will catch him if he falls. Like those kind of devices exist, and I think are a lot better than, um, having a nurse manually walk with the patient. I think that gives the patient more confidence, and prevents falls, and you know ultimately would improve their mobility and their strength. Um, I think when you're relying on manual patient handling, there's more fear of getting people up and moving, and so it doesn't happen as much, both from the provider side and the patient side. So I don't think that that's really a great argument.
Okay, here's another one for you. You'd think transfer and the lateral transfer would cause more injuries than repositioning, but on your table, they were not. Do you know why? Is it a function of frequency?
Hang on, sorry, repeat that question.
So it's really about lateral transfers, general transfers, patient transfers versus repositioning a patient. Looking at the the questioner suggests that um, lateral transfer would be more risky, a riskier maneuver, and cause more injuries than repositioning the patient. But you suggested in your table that that they were not. That repositioning had the higher
Uh,
injury rate, and the questioner is curious as to why. If it and it could it be a function of frequency? That is to say, it just happens so often. The repositioning happens so often that's
yeah.
really becomes the more dangerous maneuver.
I mean, I think there is something to be said for the frequency since, yeah, repositioning happens a lot. But I also think that just the manual techniques that we have to laterally transfer people is a lot better than the techniques we have for repositioning people. I think, you know, generally you have multiple staff available to assist with moving a patient, and you can kind of prevent the patient from, wiggling or being kind of loosey goosey by having them cross their arms and everything like that. And so it's a little bit more controlled than with lateral transfers. And so that's why I don't think that it's quite as dangerous. With repositioning, there's just a lot of different variables. It and um, you don't necessarily have like the staff, right, the additional staff helping you. move the patient. Um, so I think, yeah, I think that repositioning just in itself is more dangerous. Um,
Okay.
yeah.
How can organizations overcome resistance to change and ensure consistent adoption of these solutions?
Um,
$64,000 question.
resistant, yeah, resistance to change. I mean, I think amongst like nursing staff, I don't think that there would be much resistance, because I think they would really appreciate knowing that the hospital actually cares about their safety. Um, Probably the most resistance would come from like people on top, just because there's a lot of initial investment that goes into, purchasing all the equipment and making sure that you have a real system in place um, for ensuring that that equipment is going to be used. So I think that's probably where a lot of the resistance is. And I would again say the best way to overcome it is probably the financial argument. Um, and I mean, like, these hospitals that have implemented good programs, they make up the money very quickly. And then they have better patient outcomes, better staff outcomes. Their staff, you know, are retained better and are happier. Like it's just, a win-win for everybody. So I feel like kind of making that argument is probably the way to go.
Well, I'll make one comment here from a participant in the webinar. And she says, we have staff who don't use blowers with the air-assisted transfer
Oh
mats,
no.
and they have ceiling lifts that go unused, and it's frustrating. And you can hear that frustration. So
Yeah.
that sounds like maybe not the leadership, maybe it's some staff that are choosing to not
Yeah.
use some of this equipment.
Right, right. So, I mean, I think again that goes back to like really trying to push a safety culture, um, and you know, create that expectation that you're going to use the lift equipment. Um, I guess.
Um, there's somebody has shared a resource, and I'll mention it here now. Association of Safe Patient Handling Professionals.
Yes.
I'll let you Google that, but it's the asphp.org, and that is appears to be a helpful resource surrounding this discussion. I will leave that as a comment. Um, Someone else adds that it could it be that the longer work hours, so 12-hour shifts and so forth, contribute to the higher injury rate? This would be associated with perhaps worker fatigue and then being exposed to these lifts. Have you looked at that?
Yeah, that's a really good question or comment. I think you're right. I mean, I didn't I didn't like look into that specifically, whether like 8 hour versus 12-hour shifts make it more dangerous, but certainly I think the concept is sound. So yeah.
We also have more people saying, what advice, if any, if you could to give to encourage the support from leadership on ceiling lifts and other devices, I would imagine, being installed in hospitals. What's the motivating factors here? How could one go about lighting that fire?
Um, I think the again the financials and the fact that you're gonna you save a lot of money on workers' compensation, save a lot of money on patient falls, or well, I don't know if you lose money, but on like decubitus ulcers, the length of stay for patients is generally shorter when you're able to get them, moving more, which I don't know. I guess suppose ceiling lifts doesn't necessarily contribute to that, but um, I think it has to be just like the financial component, the mix of
Sure,
finances and the benefit to the patient, because I think at the end of the day, the patient is probably a higher priority than the staff for leadership. So I think those would be the points that I would focus on.
okay. So this is another Questioner here, you've addressed the need for lift equipment very clearly to reduce the hazard. But one thing that we've found, I work for the largest union for registered nurses, is
Mhm.
that just having equipment doesn't replace the need for additional staff. I would love
Oh
to
yeah.
hear you address the need for lift teams and to make safe patient handling programs effective. Thank you.
Yeah, I think definitely being short-staffed is um one contributes to injuries, right? Because that means you're more pressed for time and um yeah, let me see what else was the question?
Oh, I'm sorry.
Oh,
I've
here we
moved
go.
on
I lost it. I was
to
looking at it too. Um
I
oh,
apologize. It's
talking
bounced.
about money for lift teams and stuff. You don't necessarily need to have lift teams, but one of the recommendations is to have like lift champion or safe patient handling champions, right? So somebody on the floor who is there dedicated to kind of make sure that equipment is ready to go and help people use the equipment, encourage people to use the equipment, and kind of it's just a person on staff, like on shift, who's just um, knows the ins and outs of the lift equipment and can support other staff in using it. So that's something that is maybe more feasible, probably more feasible um, for a lot of hospitals than actually hiring people exclusively for lift teams. But I will say, I mean, so there was one case study of a hospital in South Carolina who enacted a safe patient handling program, and they cut their nursing turnover in half. And so I think if you just have a program like that, then maybe, nursing retention will be better, and maybe people will, the people you hire will stick around, and mm, maybe you won't be so short-staffed, you know?
Sure.
But I didn't read any data about that, like um about whether it helps over. Well, I mean it does because you retain your nurses better. So yeah, so it can help with that.
There's a comment that says, it isn't always a choice. There are so few staff on units now that nurses often don't have the assistance they need to use the lifts.
Mm.
The lifts mostly can't be operated safely by one person.
Yeah,
Having staff designated and trained to assist with lifts is an essential part of making the equipment available to nurse use. That makes a
yeah,
lot of sense.
that's a good point. Yeah.
Well,
Yeah.
we've come to the top of the hour. There are a couple of questions I didn't get to. I apologize. I've captured the spirit of most of them, I believe.
Okay.
Um, so you can learn more and register for our upcoming events at coeh.berkeley.edu. That's coeh.berkeley.edu. You can also subscribe to our YouTube channel where you can find recordings of most of our previous webinars and events. As a reminder, if you participated, if you logged in via your registration email today, you will receive a link to an evaluation form that qualifies you for a certificate of completion worth one continuing education contact hour. If you have any questions for us here at COEH Northern California, you can drop us a line at coehce@berkeley.edu. That's coehce at berkeley.edu. I want to have a big thank you to our presenter, Dr. Danya Kiydal today. It was an excellent topic. We certainly need to hear more about it. And it seems like there's a lot more that can be done. Dr. Kiydal, do you have any final words of wisdom for us?
Um, no, not really. Thank you.
Okay. Well, thanks, everybody. We'll see you at the next one. Uh, until then, be safe. Bye-bye.
All right, take care. Thank you.